a general oh, okay. Sorry, you can hear me, right? Everyone can hear me? Yes.
I can hear
Okay.
you.
Yes.
Okay. And I'm going to start off by giving a general overview of dental infection control and CDC guidelines. So I'm going to share my screen right now. Here. Presentation mode. Okay. I don't know if I can pull this over here. Don't need that. I probably don't need that. Okay, let's get started. These were our kind of objectives. We're going to talk about IPC, infection prevention and control, talk about some dental unit water lines, and review our resources that we have available. So let's talk about some of CDC guidelines. We just get this question asked a lot. What exactly is a CDC guideline? We have a few years ago, they published an MMWR article on standards required for the development of CDC evidence-based guidelines. And this was actually to help with a lot of questions, especially during the COVID pandemic. When guidelines were being created or guidance documents were being created and changed as new evidence came available. So it was an effort to help increase transparency and understanding of how CDC makes guidelines or guidance documents, things like that. So CDC guidelines are any document that's issued under our agency authority that contains recommendations for clinical practice or public health policy. Typically, there's three different kinds. There's interim, standard, or an update, and I think we'll have examples of all three here. Interim are guidances or guidelines that are created typically in new situations when there's emerging evidence, and they may be expected to change as new evidence becomes available. They're meant to respond to emerging issues or threats. Standard guidelines are some of the ones you're probably used to seeing in infection control. Those are typically based on, scientific reviews of evidence and are, evidence-based guidelines that you're used to being seen. And then updates are when we, update existing recommendations with new evidence and new science. And why are they important? Obviously, because both our patients and you, the dental personnel, staff, can be exposed to disease-causing organisms during care and potentially not when you're in care. Contact with blood, oral, and respiratory secretions and contaminated equipment occurs during work in dental clinics and dental settings, and then proper procedures can prevent these transmissions among patients and also healthcare personnel. So this slide, actually, when I look at it, I realize it needs to be updated because what you see here is kind of just a general figure of potential routes of disease transmissions in dental settings. And this here, dental healthcare personnel or staff, patients. And typically, I think when you're first starting out in dentistry and in school and stuff, a lot of emphasis is put on patients potentially transmitting infections to dental healthcare personnel. And it's good to be obviously very important to be trained on that because that can potentially happen. And as this kind of arrow is the biggest, it does show that actually dental healthcare personnel are at the greatest risk of getting a potential disease transmission just because you are exposed to respiratory and secretions and other bodily fluids all day long. So your risk of exposure is much higher than a patient. But diseases can be transmitted from patient to patient. And from actually staff to patients. And what we actually see and what's missing here is another staff over here, or dental healthcare personnel, sorry. We can actually transmit diseases from staff to staff in between, our staff members. And that's actually a lot of what we saw during the COVID pandemic. So not only are we at risk when we're treating patients, but we can potentially actually be at risk from the other dental healthcare personnel in our clinics. So here is just a list of some examples of diseases and organisms in healthcare settings. There's a really nice website on healthcare-associated infections. And actually, what we meant to say is that our CDC website just went through a big overhaul. We have lots of new materials and different formats on the CDC site, and I think it either went yesterday or today. Dr. Huynh can correct me, but some of our links down here might not work, so we're going to be sending out an updated PowerPoint with all the links. So I think, this site looks a little bit different, but this is just an example of potential disease transmissions that have occurred in healthcare settings. Now, not all of these have occurred in dental settings. So we can learn from outbreaks and disease transmissions from other healthcare settings. Now, we will go through some of the ones that have been identified in dental settings, but sometimes we believe that these are obviously probably the tip of the iceberg. There's lots of reasons why you can't identify every problem or every issue in a dental setting. For number one, we're probably not looking for them. Is dental even a question of concern when a patient is diagnosed with some type of infectious, condition? Sometimes there's a very long lag time between a dental procedure and evidence of infection. Um, we may not be following up. State or health or local authorities may not have the resources to be able to investigate every type of infection they found. So there's a lot of reasons why we may not have found these in dental settings, but it doesn't mean that they haven't occurred. And so what are some potential outcomes from an healthcare associated outbreak infection? Obviously, you can have adverse patient outcomes. Patients can get very sick and have long-term complications from an infection. We can potentially have to go through patient notification and testing. We have worker safety concerns, remediation of any deficiencies or breaches that we found, training and education, potentially clinic exposures, license suspensions, legal actions, and policy changes. So there's a lot of different outcomes that can occur from uh, uh, disease transmission in a dental setting. And again, we don't want to follow proper infection control practices just because there might be a potential disease transmission. We always want to just be able to always provide safe care for our patients and for our staff when we're in dental settings. But, here are some examples of kind of worst case scenarios of what can happen. So here's some examples again. The most recent one we see, and this was a new one. Again, we'd never seen something like this in a dental clinic. In 2023, there was an outbreak of tuberculosis among patients exposed to surgical and dental bone graft material. Unfortunately, this had occurred in spinal surgeries in the past, but it had never been linked to a dental allograft product. And unfortunately, this occurred across 7 states. This was a large outbreak where a donor had been infected with tuberculosis, and then they used the bone in the allograft procedure, and subsequently patients got infected. And this was an effort between CDC, the Food and Drug Administration, and many state and health departments to follow up on something like this. And this was a novel thing that we had never seen in a dental clinic before. In 2021, here's an example of a dentist, actually a healthcare personnel, who potentially exposed some patients in a correctional facility to SARS-CoV-2. And I think this outbreak was confounded by additional potential other exposures from other staff in the facility or something like that. But this is an example of something where you can see in a congregate living facility how quickly things can spread among the people living there. And potentially, this was a case where dental personnel potentially was positive with SARS-CoV-2, and potentially was one of the contributing factors to an outbreak in this correctional facility. Here's an example in 2014 in an oral and maxillofacial surgery practice. Of something called enterococcal fecalis, and this led to endocarditis or heart infections in 15 people. And in many of these cases, which we'll discuss in next, many infection control breaches were found in that clinic specifically. Here are some examples, and we're going to talk about water later. But these are specific to water. I know dental unit water lines, if you follow dental infection control at all, dental unit water lines has been a hot topic lately, and it's very important priority here at CDC because there have been multiple outbreaks, especially among children, of non-tuberculous mycobacteria following pulpotomy procedures. So there have been 3 outbreaks that we're aware of involving, large numbers of children who, again, got very sick. And actually, sometimes I like to share my screen. I didn't put a picture of this up, but this is an article from NPR. Oh, I can't move that. How do I move that? Here is an outbreak that was on NPR that shows, this young girl did contract an infection after she received dental care at a clinic in California, and she had 3 permanent teeth, 1 baby tooth, and a part of her jaw removed as a consequence of that infection. So unfortunately, children involved in these outbreaks did get very sick, may have had long-term complications and issues associated with those. There also have been some case reports of, bugs that are found in the water causing infections after dental procedures. Here's some references if you'd like to learn a little bit more about those cases. So what have we learned from these? Most all of these, case reports and outbreaks have included reported breakdowns in basic infection control procedures. They do highlight the need for comprehensive training to understand IPC practices. And especially the ones associated with general unit water lines. The largest occurred, pediatric dental clinics among children who had pulpotomies. All were linked to contaminated dental unit water lines where the levels of bacteria in the water were much, much higher than recommended. And the clinics weren't maintaining their water lines and testing their water lines frequently to see if they were within the recommended limits. They demonstrated lapses of compliance, which I said, and then there were some other additionally complicating factors, sometimes with the plumbings in the building. So what are some challenges that we do see in dental settings? Obviously, lack of source control for patients, especially during the COVID pandemic, we had a lot of questions about that because we did during times of recommending source control, obviously dental patients can't wear source control and you sit very close to a patient. You're doing procedures that may induce coughing or splashing and using equipment that creates spray and spatter. We have alternative settings where we're doing these types of procedures, mobile clinics, school-based programs, different places to set up. You can see some unique setups that people will do. We are typically performing all our own reprocessing in dental clinics, and sometimes, the equipment for the other clinics that you might be also doing. So you have a lot of responsibility in the clinics. We have limited regulatory oversight. There's not a lot of, regulating bodies coming in and providing kind of I'm blanking on the word, but and also lack of surveillance system, like we discussed. There's no reporting mechanism for infectious, infections and post-op infections and things in dental settings. So we're not looking for a lot of them. A lot of the times these outbreaks are identified by an observant healthcare personnel in a in a hospital setting, or somebody who is seeing the aftermath of the infections, and putting the clues together to determine, well, all of these people have something similar in common and they were all treated at a certain clinic, things like that. So what are the guidelines that we want you guys to be familiar with here? The current infection control guidelines that we have for all healthcare settings are what we call the IPC guidelines for the COVID-19 pandemic. They continue to remain the primary IPC guidance for all U.S. settings where healthcare is delivered. It's divided into two sections. It has routine practices and then practices for when you're caring with a suspected or confirmed COVID patient. And then we do have a section on there for specific dental specific recommendations. And I can share my screen with you really quick because I can go to it. And this is the document here. In the last time it was updated was May 8th, 2023. And it will potentially, I think, anytime it will be updated again, may be representative of what's going on with updates to our other infection control recommendations that are happening through our advisory committees. But what you can see on this side is you have routine practices here. We have recommended practices for when you're caring for a suspected or confirmed SARS-CoV-2 patient. And hopefully what we recommend, what we say in here is really if a patient thinks that they have a respiratory disease or are positive or exposed to COVID-19, they should postpone their routine dental care, and it should only really be an emergency if you're ever treating a COVID patient for a dental setting. And here you can see, here's the routine recommended practices. For example, we get a lot of questions about source control. So if you're looking for recommendations on what do we recommend right now for source control, this is some background information on source control and the options you can choose. But really what we recommend right now, you can see the recommendation here. Source control is recommended for individuals in healthcare settings who have suspected or confirmed SARS-CoV-2 or a respiratory infection, or have had a high-risk exposure or close contact. So right now, we really only recommend, this is basically in line with respiratory hygiene and cough etiquette practices. If you have a respiratory disease and you're in a healthcare setting, or if you've had a high-risk exposure, that's when you should be wearing a mask or source control in a healthcare setting. Now, we have some other considerations here that you may want to take into consideration if you want to implement a broader masking policy, like if disease levels are increasing in your area, if you have other indications, potentially you work with very high-risk patients, and also potentially if you are working with people who can't wear source control, anything that potentially increases your risk of respiratory infections, you can develop your own policy and you can take those into consideration. So there's some information in here about how to do that. And we actually also have an appendix all the way at the back. So this document includes those sections. It has setting specific considerations here. So here are dental considerations, and here's where we say, it should only be provided if medically necessary to someone who is sick. And down here, we also have an appendix, and here's some considerations you can take into account if you'd like to have broader use of masking in your facility. So there's a lot of information in here to go over. If you ever have any specific questions about what's in this document, that's what we're here for, and that's what we want to answer those questions and help people, understand how to implement this actually in their facilities. So that's our primary document for IPC. We also have our guidelines for infection control in dental healthcare settings. These are more specific, to dental. We are in the process of updating these. The first topic we're taking on is dental unit water lines. And that's because of these outbreaks that we've had in children, and we released a health alert in 2022 on this topic. Some people, in dental settings are not familiar with the Health Alert Network or a HAN. So we've been trying to promote this. It's for all kinds of public health emergencies and public health information. And it's great to go to this website and be on this listserv to get the information about it from the HAN network. This was the first time that we've ever done one specifically for dental. And again, here are our recommendations for dental, water lines, and whenever I've personally been involved visiting IHS clinics and other clinics, like we've been working with to do infection control assessments in. I think that people who are interested in infection control really generally do a really good job with dental unit water lines. Unfortunately, I think there are some challenges with it, and there's a lot of different types of equipment you have to use. There's the instructions you have to follow for your actual chair and your water bottle system or whatever type of operatory you're using, the maintenance product, the shock or the straw or the tablet that you're using, and then also the frequency of the test. When do you test? How often do you test? What do you do if you have a high number? So the CDC recommendations right now for dealing with water lines are very short and to the point. And basically we say, use water that meets EPA regulatory standards for drinking water, which is less than 500 CFU per milliliter. You should be following your manufacturer's instructions for how to maintain your water and how to monitor your water, which means testing your water. And you should also use sterile water or sterile irrigating solutions when performing oral surgical procedures. So you should never use water that comes out of the dental unit for an oral surgical procedure. And again, why are we starting with dental unit water lines? Because we've had these multiple documented disease transmissions. Our recommendations don't really address type or quality of water. We don't have a specific recommendation for the frequency of how often you should monitor your water. We don't have any information on how follow-up steps for what to do if your results exceed that limit. And we also have no recommendation for use of water during endodontic procedures. So those are the things that we're looking to potentially provide in this updated guideline. So we did work with one of the advisory committees here at CDC, which is the Healthcare Infection Control Practices Advisory Committee, to create a work group to help update that section of the guidelines. We have a wide variety of experts on that panel, and we are hoping to get that guideline updated probably within the next, we've been working on it for about 6 months now, but it's typically supposed to take almost up to 2 years, unfortunately. What are some of the resources that we have available for you? This is the summary. If you guys have ever been to any of CDC training courses or OSAP boot camps, typically they give these away. You can actually order free copies of these on our website as well. This is a summary of infection prevention practices in dental settings. It emphasizes standard precautions. It supplements our 2003 recommendations, but it's a very easy to use, easy to understand resource to summarize basic infection control practices. So it's a great resource to have on hand if you're looking for, what's the CDC recommendation on this specific thing in a dental setting. We have a checklist, which is used to evaluate compliance with our recommendations, and really part of it we recommended to use as a tool to perform at least annually, at least once a year, to just do an overall assessment evaluation of your infection control practices. Is pretty long. It would take you quite a long time to do the whole thing start to finish, but you can break it up and do sections at once. We also have a policy and practices section, and then there's also an observational checklist. So you can follow, that's meant to follow as you walk around and assess your facility while people are practicing. And you can see if they're following our specific hand hygiene practices. And if they're not, you can perform an assessment, write up some notes, look for areas of improvement, and try to, correct and improve the practice and provide feedback to your staff. We don't collect any data from this. We have a mobile app. We have been working on getting some feedback on that app and other types of resources that may be more useful in the future, because again, this is typically meant really to be used on a tablet, but it's good to have on a mobile just in case you ever needed to pull up resources, links to information, and you can go through and do an assessment on your phone or tablet and export that out and have a PDF copy of it for your records so that you could be using it as you go, as opposed to having maybe a clipboard and piece of paper. We do have a training course. This is a basic training course. It's available for free. It's an overall IPC course for dental settings. You can earn 3 free continuing credits from OSAP for that. You do have to create a account on CDC Train to do that, but once you're in there, there's access to a lot of other training resources there too. So our website, which is new, has a lot of information on it too. It does have links to our guidelines and guidance documents. It has a lot of frequently asked questions. It has links to our training courses and resources. So our future efforts, again, our updated website. We've recently released some funding opportunity announcements for state promotion of strategies to advance oral health, and then partners to support those efforts. And those include really partnership activities and promotion of IPC resources, especially in settings that provide evidence-based dental services, evidence-based preventive dental services to high-risk populations. Those are really the settings we really want to focus our efforts on going forward. So we do have also a contract, a 5-year contract with OSAP, the Organization for Safety, Asepsis, and Prevention. And we'd really like to start developing more targeted resources. We have some listening sessions where we're trying to get feedback from audiences regarding what type of what's a challenge in your setting, what type of resources are you looking for, what could we potentially provide that would be helpful to your clinic. And we've also we did a 2016 assessment of state dental practice acts for where they mention adherence to CDC guidelines, and also which states require continuing education in infection control. So we're updating that assessment to see how that has changed since 2016. So again, what we really want to focus on in the future is focusing our resources and attention on settings that provide evidence-based dental services and evidence-based preventive dental services to high-risk populations. So if you're interested, also if you're interested in those listening sessions, please, you can reach out to us and we can give you more information about those. And that, I am done, and I'm going to turn it over to Dr. Huynh. Oh, escape. Stop share, stop share. Okay.
Hi, does everyone see the screen okay?
Yes.
Do you see like my notes at all, or do you just see the
Just the presentation so far.
just the presentation? What about now? Is it okay? Is that still just a presentation?
That is presentation mode. Yes.
Oh, prisoner mode. Okay.
Yeah, it
Let
looks
me,
good. No,
it,
it's
it
we
looks
we see.
okay.
Yeah,
Okay,
yeah,
so you guys see the presentation, not the presenter mode?
Yeah, it looks
yeah.
good.
We see the presentation.
Okay,
Sorry.
perfect. I'm sorry about that. Okay, so good afternoon, everyone. Like Dr. Neuburger mentioned, thank you so much for having us here today. I'm going to switch gears and talk about antibiotic prescribing and stewardship in dentistry. So the objectives of today's talk is to provide an overview of antibiotic stewardship and its application in the dental setting, summarize current national dental antibiotic prescribing data, and discuss some resources available for dental stewardship implementation. So before we get started, just a little bit of background. Antibiotic use is the primary driver of antibiotic resistance. CDC's most recent antibiotic resistance threats report estimates that annually more than 2.8 million infections and close to 36,000 deaths occur due to antibiotic resistant infections in the US. In addition, antibiotic use can lead to adverse events and other complications. 1 out of every 1,000 antibiotic prescriptions leads to an emergency department visit, and this causes more than 200,000 ED visits annually in the US. Antibiotic use is also the most important modifiable risk factor for developing Clostridioides difficile infection, a potentially life-threatening gastrointestinal condition. Patients are 7 to 10 times more likely to develop C. difficile while taking an antibiotic compared to someone not on an antibiotic. And antibiotic stewardship is essential for patient safety and combating antibiotic resistance. It includes a set of commitments and actions designed to optimize the treatment of infections while also reducing adverse events associated with antibiotic use or suboptimal use. That way, patients don't receive unnecessary antibiotics, and when they do need them, they get the right antibiotic at the right dose and for the right time. And antibiotic stewardship applies to all healthcare settings, including the dental setting. There are 2 main indications for antibiotic use in dentistry. The first is treatment of dental infections, and the other is prophylaxis prior to invasive dental procedures for patients with certain high-risk conditions, mainly cardiac ones. And amoxicillin is the first-line therapy for both indications. In 2013, dentists wrote nearly 10% of all outpatient antibiotic prescriptions in the US, making them the 4th highest prescriber of antibiotics following family practitioners, pediatricians, and internists. Past studies have shown that about 80% of antibiotics prescribed for prophylaxis before dental visits were unnecessary. There's evidence of a high frequency of inappropriate prescribing by dentists, which means there are opportunities for improving by implementing antibiotic stewardship practices. As a result, there have also been national efforts to improve antibiotic use in dentistry. As part of the 2015 White House Forum on Antibiotic Stewardship, the American Dental Association, or ADA, indicated it would develop guidelines to address antibiotic use for common dental conditions. And during the 2018 to 2019 Antimicrobial Resistance Challenge, the ADA specifically pledged to create and disseminate guidance to help dentists appropriately prescribe antibiotics for dental pain and swelling. And at the end of 2019, the ADA published this treatment guideline. The guideline recommends limited antibiotic prescribing and prioritizes dental treatment instead. For most episodes of dental pain and swelling, the solution is a dental procedure, and antibiotics should only be prescribed if the patient has signs of systemic involvement, such as fevers or chills. And if the ADA's guideline was widely implemented, we would expect to see a decrease in antibiotic prescribing by dentists at the national level. And to look at recent dental prescribing patterns, we performed an analysis using national antibiotic prescription data. And our objectives were to characterize antibiotic prescribing by dentists in recent years, comparing antibiotic prescribing before and after the ADA guideline release in 2019, and examine the geographic concentration of dentists in the United States as an indicator of access to dental care. For our data sources, we use the IQVIA Exponent Prescription Database and US Census Bureau population estimates. IQVIA Exponent captures more than 92% of all US outpatient prescriptions and projects to 100% coverage. We used it to obtain oral antibiotics prescribed by dentists, as well as the number of dentists for each state. And US Census Bureau estimates were used to calculate rates. For our analysis, we included antibiotic prescriptions from 2018 to 2022, and we calculated antibiotic prescribing rates per 1,000 persons and compared dental antibiotic prescriptions to total outpatient antibiotic prescriptions. We also evaluated the concentration of dentists per 100,000 persons by state. Prescriptions by dentists were summarized by the following characteristics: sex at birth, defined as female or male; age, categorized into 5 age groups; antibiotic agent; and prescriber location by state and region. Our results showed that dentists prescribed approximately 25 million antibiotics per year during 2018 to 2022. So this means that approximately 75 antibiotic prescriptions were dispensed for every 1,000 people in the US each year. The left axis on this line graph displays the number of outpatient antibiotic prescriptions in millions, with dental antibiotic prescriptions shown in orange and total antibiotic prescriptions shown in blue. So we see that dental antibiotic prescriptions have been stable, while total antibiotic prescriptions by all prescribers have decreased. The blue bars on this graph display the percent of total antibiotic prescriptions written by dentists. Since total antibiotic prescriptions decreased during the COVID-19 pandemic, while dental prescriptions remained stable, dentists' share of antibiotic prescribing increased to more than 10% during 2020 to 2022 compared to prior years. We are currently in the process of getting finalized antibiotic prescription data for 2023 so we can see how dental prescribing is trending. The antibiotics most prescribed by dentists over the time frame were amoxicillin, clindamycin, penicillin V, azithromycin, and amoxicillin clavulanate. Amoxicillin and clindamycin accounted for nearly 80% of all antibiotics prescribed. Amoxicillin prescriptions represented by the blue line increased from 64% to 68.1% of all dental antibiotic prescriptions, while clindamycin prescriptions represented by the orange line decreased from 14.2% to 11.8% over the time frame. Now we'll look at dental antibiotic prescription rates by patient characteristics, starting with patient sex at birth. The rate per 1,000 persons is shown here on the left axis. Females, shown in blue, had higher rates of antibiotic prescriptions than males in orange. The average prescribing rate was 81 antibiotics per 1,000 females and 68 antibiotics per 1,000 males. Approximately 9 out of every 10 dental antibiotic prescriptions were for adults 20 years of age and older. Dental antibiotic prescription rates shown per 1,000 persons increase with age and are highest for individuals 65 years and older, represented by the blue line at the top of the graph. Dental antibiotic prescription rates varied by US Census region in 2022. The Northeast region had the highest prescribing rate with 86 prescriptions per 1,000 persons, while the West region had the lowest prescribing rate with 66 prescriptions per 1,000 persons. On this map, states with higher prescribing rates are shown in darker blue. The antibiotic prescription rate in the highest prescribing state was nearly double the lowest prescribing state in 2022. New York had the highest rate with 94 prescriptions per 1,000 persons, while Alaska had the lowest rate with 49 prescriptions per 1,000 persons. Here, the darker purple represents a higher concentration of dentists per 100,000 persons. Concentration of dentists varied twofold across the US in 2022. Massachusetts had 80 dentists per 100,000 persons, while Delaware had 41 dentists per 100,000 persons. And states in the South region had a lower concentration of dentists. Despite the ADA's release of an evidence-based treatment guideline in 2019, antibiotic prescribing by dentists remained stable during 2018 to 2022. Some possible explanations for high prescribing among dentists include poor dissemination and implementation of new guidelines, pressure from patients and other healthcare providers to continue prescribing according to previous patterns, or limited awareness of antibiotic use risk and the significant role that dentists play in overall antibiotic prescribing. However, antibiotic agent selection improved over the time frame. Amoxicillin prescriptions increased, representing a favorable shift towards selecting the recommended first-line agent for dental indications, and clindamycin prescriptions decreased, possibly due to growing awareness of the risk of C. diff infections related to its use. Antibiotic prescribing rates varied by patient characteristics, including sex at birth, age, and prescriber location. And the rate variation may represent differences in dental disease burden, underlying health status, access to dental care, utilization of service, or patterns of unnecessary antibiotic prescribing. The concentration of dentists varied by state. It's unclear what impact this has on antibiotic prescribing, and lack of access to dental care can result in more antibiotic prescribing for untreated dental conditions. But further evaluation of the relationship between access to dental care and antibiotic prescribing is needed. Our analysis had several limitations, many of which were inherent to the IQVIA exponent dataset used. First, there's a lack of indication for antibiotic use, so appropriateness of prescriptions could not be assessed. Second, antibiotics prescribed by medical providers and dental specialists were not captured in this analysis. So this is an underestimate of all antibiotic prescribing for dental-related conditions. And lastly, there's limited social demographic variables available in the IQVIA dataset, so we can't discern if prescribing disparities exist for certain characteristics such as race or ethnicity. And antibiotic stewardship is needed to improve prescribing in dentistry. This includes widespread dissemination of the current ADA treatment guideline, along with interventions to change prescribing behavior among dentists. The core elements of outpatient antibiotic stewardship framework can be used in the dental setting to improve antibiotic use. The 4 core elements are commitment from leadership, action for policy and practice, tracking and reporting of antibiotic use, and education for prescribers as well as patients. Because dentists prescribe antibiotics as prophylaxis before some dental procedures and for treatment of dental infections, dentists and dental clinics are an intended audience of the core elements of outpatient antibiotic stewardship. This framework should be considered when implementing best practices in the dental setting. CDC is supporting dental antibiotic stewardship efforts by building partnerships with dental organizations, updating and creating new content on appropriate antibiotic use tailored to dental prescribers, and disseminating resources to dentists through CE courses, an annual summit, and webinars like this one. And CDC is working with OSAP to try to improve dental antibiotic prescribing for both dental infections and prophylaxis. As Dr. Neuburger mentioned before, CDC is funding OSAP through a cooperative agreement to update and develop new communication materials and website content on appropriate antibiotic use, as well as to disseminate antibiotic stewardship resources, tools, and clinical practice guidelines. OSAP's website content on appropriate antibiotic use can be accessed through the QR code here, and it includes educational material with up-to-date information for dental prescribers, the dental team, policymakers, and patients. CDC also has several resources available related to appropriate antibiotic use in dentistry for a variety of audiences. The audience for these materials include patients, dentists, health departments, and others involved with dental antibiotic stewardship activities. And for patients, we've created communication materials that include antibiotic safety do's and don'ts at the dentist and antibiotic use for a safe dental visit. For dentists, we have a checklist for antibiotic prescribing in dentistry that is being updated to reflect current antibiotic prescribing best practices, and our Be Antibiotics Aware treating patients with dental pain and swelling resource. It's an easy to use guide summarizing the ADA's clinical practice guidelines for treating dental infections. For those interested in learning more about antibiotic stewardship considerations in dentistry, CDC does, as mentioned before, has a resource that can be distributed to anyone working in dental facilities or with them to improve antibiotic prescribing. And here's a list of resources that are available from CDC, including the ones mentioned previously. And I'll end my talk with this take-home message. Dentists write millions of antibiotic prescriptions each year and have high prescribing rates. Engaging dentists in antibiotic stewardship activities is important to improve prescribing practices. And even though there's more work to be done, we can see that dental stewardship is starting to get the attention it deserves from a wider audience. And I hope that together we can improve dental antibiotic prescribing, and we need to, because appropriate antibiotic use is essential for both patient safety and public health. Thank you. And we'll go ahead and take any questions you all might have.
Thank you for your presentation, and thank you for the presentation, Dr. Neuburger and Lieutenant Commander Huynh. We are now going to move to the Q&A portion of our call. So if you have any questions, please raise your hand or speak or type in a question in the comments in the chat box. And we do have a couple questions here. I'll go ahead and open here. Where can I find, I believe this will be for both Dr. Neuburger and Lieutenant Commander Huynh. Where can I find more information on data collection and antimicrobial stewardship program metrics?
Do you mean really in the dental setting specifically?
I just reading a question.
Oh, okay. Okay. So I guess
I'm assuming it is in a dental setting.
And I think that's, at least I'll speak first, Dr. Neuburger, but I think, related to our project, it's difficult to find like a national data set. Certain healthcare systems like the VA that has an integrated electronic health record with their electronic dental record, they're able to do some studies related to appropriateness of antibiotic use. But in terms of use overall, that's why, for this project, we ended up using a claims data set to have like a national representative level to look at prescribing patterns and trends over time.
Mm-hmm. Yeah, and I would say specifically, it's a good point. I don't know if you're asking about like auditing practices or a tool or a resource for a clinic to perform an audit within their facility of antibiotic prescribing practices. I don't know if Dr. Huynh is familiar with one of those tool or auditing specifically for a dental setting. I'm not. I think it kind of piqued my thoughts, and I thought, well, that's something potentially we could look into, and if we find something about that, we could send that to you. Because I know, larger organizations may have created a template or a tool that they like to use, and then individual clinics may have their own ways of doing it. And then specifically, using, I think one of the best resources that Dr. Huynh presented was that antibiotic do and don't checklist of when exactly we recommend, or the ADA guidelines recommend prescribing antibiotics. And you can kind of assess your clinic's facilities practices of whether you're, do an internal audit to see if you're actually prescribing antibiotics in align with those recommendations.
Hi, my name's Emily McDonald. I work with CAM in the Office of Antibiotic Stewardship. So I'll just add that OSAP, they do have an audit and feedback tool that you can access to, do some of that tracking at the clinic level. We do know that's kind of a laborious process to do at that level, but that, as Cam said, dental data is kind of limited at a larger level to do that kind of tracking and auditing and feedback.
Okay. Thank you. I think that's what I had in my mind. I just couldn't remember where I saw it. Thank you.
I have a question, and this is for Dr. Neuburger's presentation. I was kind of shocked by, well, not really, but about the stat that you had mentioned about prisoners or incarcerated individuals getting COVID while receiving dental care. Do you know if there was any other infectious diseases that were reported that, incarcerated individuals get while receiving dental care in prison?
I am not aware of any additional like documented case reports on that, but
because I do hear stories like, they may not have
Yeah.
had the best dental care in prison. So I guess I was kind of feeling sympathetic to that population. So
Yeah, I agree. I think that they have, some challenges with resources there. And, unfortunately, again, like we said, we don't have a lot of documented evidence, but we do hear anecdotal, single case reports, things like that, things maybe that may not be reported, some things in the private practice that, are potentially, are identified kind of through a lawsuit or a legal action, and then the case files are closed, things like that. So unfortunately we don't, but we obviously know again, I mean, those are the settings that we really want to work with. We want to work more closely with, the Bureau of Prisons, additional, organizations like that again, because they're one of our high need, high priority, high risk settings. And you can see again, I mean, there's a lot of uh, work here, I think, in special populations. They're a team that works specifically with correctional facilities on that and especially because of the congregate living facility and how quickly and the risks that come with that population and how quickly things can spread because of that. So I really appreciate your comment. Thank you.
Thank you for that question. Do we have any other questions for either one of our presenters?
I have another question, and this is for Dr. Huynh. Um, was it, I think I heard you, was clindamycin, was that associated with more adverse events than amoxicillin?
It's typically tied to use of it is tied to a higher risk of C. diff infection. And usually, amoxicillin is the first line of therapy because you want something that is, more narrow spectrum to kind of, get at the bug so that you don't cause the resistance, right? Because every time you use antibiotics, right, there's that risk of building resistance, and you're affecting your microbiome as well, and that lasts well after you finish the course of the antibiotic therapy.
Okay, so do you know if like a dose of clindamycin can cause C. diff, or is
I
that
I
not
think
proven yet?
you have to take it into account considering what
Oh,
other
okay.
like comorbidity conditions you might have as well. So I don't know if that kind of answers your question. It's been associated with a higher risk, but
Oh, okay.
that's not to say how many doses you get would put you at
I'll
risk,
add,
right?
yes, it's possible that somebody can get C. diff from just one dose
Oh,
of
wow.
prophylaxis. Obviously, risk increases with the length of time that you're on it, but even one dose gives that same, risk.
Okay. Wow, that's
Yeah.
shocking to know. So then I'm assuming amoxicillin is um the way to go as far as prescribing antibiotics.
Taking into consideration, yeah,
Okay.
allergies or whatnot, yeah. And clindamycin is no longer recommended as an antibiotic prophylaxis
Oh, thank you.
before invasive dental procedures.
Thank you for the question, Hiram. Do we have any additional questions? And I have one that's been sent in. Does CDC have position statements on antimicrobial stewardship?
I'm not sure about a position statement. I don't know if Emily knows, or Dr. or Michele, if they can add to that, but that is something, that um, uh, is very important, and is a high priority in terms of, it's considered a public health threat.
I don't know about specifically a position statement, but we have the framework for implementing antibiotic stewardship in the outpatient setting. So CDC's core elements for different healthcare settings.
I see there's a question.
Yes, we have a question from someone has their hand up. Go ahead and ask your question.
Hi, this is Z. I have a question about position statement. I think they're maybe referring to the CSTE process, and they definitely have a position statement on this.
Thank you for that. I appreciate that.
I have another question. Sorry, you guys. So I went to my dentist, and I noticed that they had certification within dental IPC. So would you recommend people looking for a dental clinic that is certified in IPC so that we know, this dental clinic has had, training on IPC measures and making sure it's clean and safe for the patient?
Yeah, absolutely. I love hearing that. I will say that that is a newer certification course that's only been out for, I'm not sure how long, maybe a year or two. And OSAP work with Dale Danby and the dental assisting boards to create these new certification courses in dental infection control. We'd never had anything like that before. And people who maybe are used to working in medical infection prevention and infection preventionists and stuff, but they know there's a lot of resources and trainings and certifications out there on the medical side, but we never had that for dental. So we're really excited to see that there is a certificate course and an actual certification course for dental staff to be able to do these things. So yeah, absolutely. I mean, you can look for that. OSAB also creates resources for patients to really have the conversation with their dentists, and also really, the onus on us dental personnel to discuss with our patients. There's something called the Dental Safety Foundation, resources out there to be able to be comfortable to speak to your patients about what you do to keep them safe while they're in the dental clinic. Sorry, I know.
Yeah, and I just want to add, it also depends too on where your dental provider is licensed. I know states specifically have dental practice courses, dental infection control courses that providers are required to take. Like Dr. Neuburger said, this is something that's new. It's not mandatory. But if you do have, like she mentioned, a set of questions, that's something, that you can ask your provider, and they can provide more information on in terms of what they're doing in terms of reprocessing, and the types of instruments they're using and whatnot.
Thank you for those answers. Do we have any questions that anyone want to put in the chat? If not, we will go ahead and wrap this up. Thank you all for attending this webinar session. And I did put in the chat to please fill out today's survey and evaluation for today's session. Your feedback is very valuable to us and much appreciated. We are very committed to continual improvement, and NIHB will consider suggestions for future training needs. So I'm going ahead and turn it over to Tyrone so he can give us some announcements.
Hello, everyone. I'd just like to thank Dr. Huynh and Dr. Neuburger for being our special guest today and presenting on that topic. And I just want to state some announcements that I'm going to put in the chat. So our Tribal Infectious Disease Institute will be held as a free pre-conference session during the National Tribal Health Conference on May 20th in Rapid City, South Dakota. So if you're interested in attending that, I will put the link in the chat. And then our next IPC webinar is on July 31st, 2024 at 4 p.m. Eastern. Rose Davis, who is a nurse and the director of North Segment Home Service, will discuss C. diff and IPC measures that will help healthcare professionals prevent and respond to C. diff outbreaks. And we'll also post that link. Let's see, is it going? And then we will also be contact us at infectiousdiseases@nhb.org to express interest in learning more about or participating in an IPC assessment training. This training will equip individuals with skills to support tribal health facilities and health departments in conducting ICARs. It will be a train the trainer course. So I will also put that in the chat. And then we also want to promote Indian Country Echo's webinar on the use of text messaging in 638 facilities to implement evidence-based interventions and improve care. And that is going to be on May 29th, 2024. It's a free webinar from 12 p.m. to 1 p.m. Pacific time. And I will also put that link in the chat box. And that is all we have for today. So again, thank you to Dr. Huynh and Dr. Neuburger and everyone else for attending our webinar today. Thank you and have a good day.
Thank you for having us. Thank you.